Good day, everybody. This is Chris with the Ancient Scholar. I hope this video finds you all doing well as we go into the holiday season. So I wanted to talk about some really important concepts, and in fact, these are near and dear to my heart, and I would consider myself somewhat of an early convert to the cult that I am about to mention here. And this I converted approximately 4 or 5 years ago. It was during a conference, an emergency nursing conference, and this was as I remember, this was one of the most important presentations of that entire conference. Of everything that I experienced, this one particular presentation actually completely changed the way in which I engage with a very important component of emergency medicine. And so it was just paradigm changing, and just really helped me to re-articulate the zeitgeist which I had been operating under, and that is in reference to myocardial infarction, also known as heart attack. And that particular video, I believe, and I'll see if I can just put a link to some of the references I'm going to talk about in this video down below in the description. But that particular video was Changing the STEMI Paradigm ? And this is the first time that I had encountered a concept known as OMI, or OMI. It stands for occlusion myocardial infarction. So what I want to do in the next few videos is I want to talk about some of the lead up to where we're currently at, and provide some of the background. And this is actually, as far as medicine goes, this is fairly contemporary stuff. This really came out of data that was collected in the 80s and 90s, and people were looking at ECGs, and we're just noticing trends and noticing that there were certain changes that were strongly associated with an occlusion of a coronary artery and the resultant ischemia, infarction, and injury that occurs in the absence of blood flow. And this was thought to be an acute kinds of situation. So, the concept of a heart attack is certainly not a new one, but the mechanisms and the specific electrocardiographic findings associated with a heart attack is a bit more contemporary. It's, I would say, the last few decades we've kind of solidified certain paradigms for looking at this. Anyway, so from that data, there initially came the thought of certain kinds of acute situations that would result in an acute or a sudden lack of blood flow to the myocardium, to the heart. And at the time, these were, and again, we're going back a couple decades, at least the data, 2-3 decades, right in there. I'm gonna be a little loosey-goosey with the exact dates, but the original terms, and some of you old school providers may actually remember some of this terminology, but there was the term of a transmural myocardial infarction, and that is involving the entire thickness of the myocardium, or a significant portion the thickness of the myocardium. And then there is something known as subendocardial myocardial infarction, which involves partial thickness of the myocardial wall. And then there was associated with that this concept of a Q wave myocardial infarction, and we know that pathological Q waves are associated with death or infarction of muscle, of myocardial muscle, myocardium. And then there's this concept of non-Q wave myocardial infarction, where you don't have significant pathological Q waves develop, but you still have an acute compromise of perfusion. And then that kind of got further solidified into the more contemporary paradigm, which we still use to this day, and that is this concept of there's something called an acute coronary syndrome, an ACS, and that's a constellation of findings associated with the acute acute compromise of blood flow to the heart, and oftentimes this can be a complete loss of blood flow, and we can quantify that a little bit in angiography by something known as the TEMI, or thrombolysis and myocardial infarction blood flow scheme, and it goes from a 0 to 3, 0 being no distal flow whatsoever beyond a certain diseased section of an artery, all the way up to TEMI 3, which is robust distal penetration of blood flow to include good collateral circulation and then everything in between. But going back to that, there's this concept of an acute coronary syndrome. Oftentimes this is due to the rupture of a plaque, and so you have plaques over years and decades, and we all have this to varying degrees. You get coronary artery disease that develops, and you have primarily atherosclerosis and arteriosclerosis. You kind of have a hardening of the arteries, and then you have the development of these plaques. And over time, the plaques can kind of slowly occlude the coronary artery, and then if that's really severe, and that can lead to more chronic low blood flow states, you can get kind of the more chronic manifestations of coronary artery disease, like angina pectoris and things of that nature. But when that plaque ruptures, so the stability of the plaque is actually really important. When a plaque becomes unstable and it ruptures, then that acute event results in a whole series of events that can produce a blood clot, essentially. And that blood clot can occlude that vessel where that plaque rupture occurred, and then that can compromise distal blood flow. And this doesn't necessarily have to happen in the heart. This can happen in other areas of the body, for example, the brain, and that can cause a stroke. But we're talking about the heart for the next few videos at least. And so that's what an acute coronary syndrome is. But the acute coronary syndrome can manifest in certain ways. And these manifestations of classically, at least in the contemporary context, are classically thought to fall into a couple of major categories based on specific electrocardiographic findings. And the categories are what we call the STEMI, the ST elevation myocardial infarction. And so what we found is the elevation of the J point above the baseline. And if you're not real clear on what that is, I actually have whole playlists of videos talking about this, so I'm not going to go into great detail, at least in this specific video that I'm doing. This is just kind of the primer to produce the foundation for understanding what the new changes are. And there are many other people that have talked about this as well, probably much better than I have. So just to throw that out there. So that information is pretty easy to find. Okay, so you have the STEMI, the ST elevation myocardial infarction, where you get elevation of the J point above baseline in contiguous leads, and that is associated with the acute occlusion of specific coronary arteries that feed into specific areas of the heart. And these elevation is indicative of injury. So you have such compromised blood flow that the myocardium itself is becoming injured, and if that goes untreated, it will infarct, and then you can get those Q waves that develop. And then the other major category of acute coronary syndromes are what we refer to as the Nstemis, or the non elevation myocardial infarction / USA, unstable angina. And we just kind of throw everything else in there. Now, and that's kind of where we've been for several years, for many years, over a decade really. This STEMI versus Nstemi, and at least just from a gestalting, I'm just kind of, how do we primarily deal with this? The contemporary thinking is, if there's STEMI, you go to cath lab and you have an angiogram, an emergent PCI, or percutaneous coronary intervention, right? A balloon angioplasty followed by a stent. So that's your immediate reperfusion strategy. And if you're incapable of doing that or unable to do that within specific timeframes, then you can think about fibrinolytic therapy in that event. And I remember a time where in the 90s, in the late 90s, when I was learning how to become a healthcare provider, the concept of PCI was not around. It certainly was not an option for the most part. It was being developed. And so fibrinolytic therapy was the primary option for a reperfusion strategy back then, but obviously things are very different now. And then the other group of acute coronary syndromes, unstable angina / Nstemi, where there isn't ST segment elevation that meets certain thresholds and certain contiguous leads, well, these patients generally would not emergently go to the cath lab. Maybe they would go within 24 to 48 hours, and there are all sorts of risk stratifications that are employed to kind of figure out, okay, who needs to go sooner. But generally speaking, STEMI would go directly to cath lab. Nstemi / USA would, generally speaking, receive some sort of medical management for about a day or so, and then go less emergently or less urgently to the cath lab. And that's kind of where we've been operating. And that's kind of where most of us in emergency medicine operate. And then we had some people that started asking a lot of questions, going, well, how legitimate is this paradigm? And is it possible that there are people that kind of fall under that Nstemi / USA umbrella, that maybe what's going on with them really requires more emergent treatment? Like maybe some number of those patients really need to go to the cath lab sooner, need to have an accelerated reperfusion time frame. And so there were a lot of people that looked at this, and I'm not going to be able to give credit to everybody, but I would say probably one of the big early proponents of this was a guy by the name of Dr. Smith. You may know him from the Smith modified Scarbosa criteria. He actually, and I'll try to link it in the description, he manages a blog, a Smith ECG blog, I think. And he was really one of the providers who was paramount in trying to push for a different paradigm. Stephen Smith, in addition to a couple of other physicians, Scott Weingart, many of you probably know him through the MCRIT podcast and the MCRIT, well, it was foam education. It's now a service that you can pay for to be part of that, but it's a part. He was one of these early adopters of this online continuing education, online podcast type education model. And I believe Pendle Myers was another physician that was involved in this. And they started kind of talking about, hey, maybe there are a lot of people that we're missing, and that could potentially be a problem. And Dr. Smith in particular, well, several people, I wouldn't say him in particular, but he was definitely an important part of that, maybe is the face of it all in some sense, started coining the term OMI, or occlusion myocardial infarction. and started talking about, maybe there is a problem with the STEMI label. And that is to say that if you all do not meet STEMI criteria, then you're somehow not, your condition is somehow not as deadly, as problematic, and therefore does not need as emergent treatment. So we kind of looked at this in some detail, and interestingly enough, and this is only really in the last few years, there have been some studies looking at, okay, well, how do Nstemi/USA patients do? What are their outcomes? And there are some studies out there. One released in the study of International Journal of Cardiology, is it Heart and Vascular Disease, something like that, was in 2020, October of 2020, so fairly contemporary, where they found that under the current paradigm of STEMI versus Nstemi/USA, 25 to 30% of patients who fell into an Nstemi diagnosis were actually found to have total occlusion when they went to the cath lab, right? And so potentially, around a quarter of patients that fall in the Nstemi category potentially would have benefited greatly in some instances by undergoing emergent cardiac catheterization, right? And so I think that really solidifies, from an evidence-based standpoint, that should really solidify this concept that, okay, maybe the STEMI label is not sensitive enough to pick up patients that are actually having a substantial myocardial infarction. And so this newer term is now proliferating, known as OMI, or OMI. It stands for occlusion myocardial infarction. And it's essentially a branch of acute coronary syndromes where it is broader, it's more inclusive, and it includes total occlusion or near total occlusion where you don't have sufficient collateral circulation, and that results in actively infarcting, injured, and dying heart tissue. And then you have, some people have even pushed that further to have what's called NOMI, or non-occlusion myocardial infarction. And essentially, in this case, you may have maybe an occlusion or substantial disease on even an acute process, but there's enough collateral circulation that you don't have active infarction. And when we start thinking about OMI versus STEMI, OMI is a little more inclusive, but then the question is, okay, so what kinds of findings, what are some reasonable findings that are associated with this concept of OMI, right? So clearly STEMI, right, if we go by classical STEMI thresholds, we may end up missing a quarter of patients. So what other things do we need to look for? And this has been the last several years, certainly since I encountered it 4 or 5 years ago. This has been kind of the current discussion, and nothing has really happened in an official. Certainly there are people pushing this hard, Dr. Weingart, Dr. Smith, and many others, but when it comes to position statements and white papers and societies, critical care societies, cardiovascular societies coming out and saying, this is what we recommend, this is the power of all of our members, and large numbers of experts agreeing on evidence, that has been somewhat lacking. And that has actually changed a bit this year, at least in my mind. So we can have a very extended discussion about what things should be looked at. But what I want to do in this video is just say, okay, these are the things that at least one significant society is recommending. And I think that it's a move in the right direction. There's certainly a lot of nuance there to be had, but at least this is a push in the right direction. And I think for the most part, we can agree on these. And beyond that, I think it's important for us to begin to, if we haven't already, to begin pushing this in our educational curricula. I know that I will be redesigning the ECG interpretation course that I teach to specifically include these findings. And I have, over the years, actually modified what I teach to include some of this, but I'm really thinking about taking another step in trying to codify it a bit more robustly. Unfortunately, I still have to talk about STEMI and use the STEMI paradigm because that is so common and so popular that if I don't include that in what I teach my paramedics and they get out into the quote unquote real world, they're going to encounter lots of providers that are going to use these older paradigms, and I still think that you need to be aware of them. You still need to understand what that means. And this new way of thinking doesn't make STEMI go away, right? So your classic STEMI, right, greater than 2 millimeters of ST segment elevation in 1 lead or more, or greater than 1 millimeter ST elevation in 2 or more contiguous leads, like that still applies, right? So there's nothing wrong with that. That's just kind of the that's the low-hanging fruit when it comes to an acute coronary syndrome that needs emergent reperfusion therapy, right? And so what we're saying is, okay, there's some higher fruit up there that we need to learn how to pick because it's getting missed and potentially leading to poor outcomes in our patients. So that's where I'm coming at that from. So in 2018, I believe, the first push in this direction, in my mind, where you have at least more than one person coming together and presenting a document, and these are experts in the field of emergency medicine, resuscitation, critical care, cardiovascular medicine, and so on. And this was I would call it a white paper of sorts. It's technically a manifesto. And this is a document known as the OMI or the OMI Manifesto. And this is a collaborative document that was produced by Dr. Pendle Myers, Dr. Scott Weingart, and of course, Dr. Stephen Smith. And this is a really nice document. It's about 35 pages or so, maybe about 40 pages with the references. And they kind of sum all this up, what I've talked about for the last 20 or so minutes. And they really make the case for, hey, we need to change the way in which we look at acute coronary occlusion, and we need to broaden out what we consider. We need to broaden the types of patients that need to go to the cath lab more emergently. All right. And so it's a good paper, it's a good document. I'll try to put a link to it in the description here to this video. Okay, and so we've had this manifesto. We've had several people kind of out there preaching, and then you've got people like me who are converting to this cult, so to speak, this OMI cult, and finally. We now have an organization that has published expert consensus guidelines. And this is the American College of Cardiology, or the ACC. And this was published in October of 2022. It's very contemporary, and this is the 2022 American College of Cardiology Consensus Statement. The actual document is Expert Consensus Decision Pathway on the Evaluation and Disposition of Acute Chest Pain in the Emergency Department, a report of the American College of Cardiology Solution Set Oversight Committee. All right, so I think this is the first big step in a different direction. So what they have done is they have not actually embraced the OMI moniker, which is, it's too bad. But what they have done instead is they've said, hey, there are certain electrocardiographic findings that when married to the clinical assessment, patient having chest pain and certain risk factors, there are certain electrocardiographic findings that should be seen as equivalent to a STEMI. All right, so you've got your classic STEMI, and then if we have these other things, you should just look at them as STEMI. So they kind of haven't embraced the OMI paradigm, the OMI moniker, and instead they're still hanging on STEMI. And maybe that's a good thing, because in medicine, you rarely have like really rapid change. It generally is you're kind of dragging people kicking and screaming to change, and you're just overwhelming them with evidence. And some people will never change their practice until they die, and you just have to wait for the dinosaurs to die out, so to speak. And sometimes we see rapid change and acceptance of certain things, but so I kind of see maybe why they decided to keep the STEMI, because it's just so ingrained in the medical zeitgeist at this point that instead of just trying to upend everything, perhaps you can get more buy-in and more people on board by saying, hey, STEMI's still there, but now there are some additional things that you should view as equivalent to STEMI. So I'm okay with that. And at least it's a step in the right direction. And so I'm just going to review the major things, and then I'm going to do some subsequent videos to actually show you what some of these things look like if you've never encountered them. If you're up on it and you're good to go, then maybe this video will be sufficient for you. And really, if you've got your ear down to the tracks on all this, you don't even need to watch. You shouldn't even be watching my video, because you already know. But really comes down to 4 major things that the ACC says should be seen as equivalent to a STEMI, which means that if they have chest pain plus these, they need to go to the cath lab emergently. So it's a step in the right direction. We're broadening out what we are going to consider a STEMI. And at the end of the day, what does that mean? What goes to the cath lab emergently? All right, so first one are what we call de Winter T waves, or de Winter sign. And I'll talk about what that is, but it has to do with the T wave morphology. The second one is posterior STEMI. All right, so STEMI of the posterior wall is interesting because a standard 12-lead ECG doesn't look at the posterior wall, but there are certain aspects of the front of the heart that are reciprocal to the posterior wall, right? And you know the concept of reciprocal changes. So that's actually really important when it comes to posterior STEMI. Third one are what we call hyperacute T waves. So it's somewhat similar to de Winter's T waves. And so acute T wave changes are actually really important. And then the fourth one is in the setting of a left bundle branch block or a ventricular paced rhythm. And so finally they're saying, hey, if you have somebody with chest pain, but they have a bundle branch block, there are some ways of evaluating the J point and the ST morphology, primarily through the concept of appropriate and inappropriate concepts of inappropriate and appropriate concordance and discordance. And classically, this has been defined as the Sgarbossa criteria. More contemporary ways of analyzing this, and perhaps easier, is through the Smith modified Sgarbossa criteria. And the ACC at this point says you can use either Sgarbossa or Smith modified Sgarbossa criteria. So those are the 4 things: de Winter's T waves, posterior STEMI, hyperacute T waves, and left bundle branch block / paste rhythms when seen through the lens of Sgarbossa criteria. If you have those 4 things, you should now consider that equivalent to a STEMI, and that is somebody who needs to go emergently to the cath lab. So that's kind of the major thing that I wanted to cover. And perhaps what I'll do is in some subsequent videos, I will actually talk about De Winter's T waves, posterior STEMI, hyperacute T waves, and some Sgarbossa or the modified Sgarbossa criteria, because it's a little easier to work with, just to demonstrate the additional steps that we should be taking. And in my mind, this is like the absolute minimum we should be doing. There's actually a much broader conversation around the concept of OMI. So don't think that this is cutting edge, because it's actually not. This is these are like these super obvious, clear things that we can be doing. But there are lots of other things out there that, like, Welland's syndrome and South African flag sign, and some of these other things that can have really subtle findings that many people are pushing to be treated like a STEMI as well. But at least we're moving in the right direction. This should be seen as the absolute minimum we should be doing, and I want to include non-physician providers in this as well, right? If you're a paramedic or you're an emergency room nurse, or you're a mid-level provider, right? You need to add this into your toolbox, and you need to start looking at your chest pain patients through this lens as well. And it's no longer just solid STEMI criteria. It's you need at a minimum add these things in, and you need to start treating these things like a full-on STEMI. All right, everyone. Hopefully you found this helpful. Hopefully my rambling wasn't too bad, and maybe I'll see you on the next video. Thank you so much. Take care.